Next, we have a very popular speaker known for his clinical acumen and skills. He has written an impeccable book on pediatric gastroenterology, which I'm sure is in each and every one of our bookshelves. He is none other than Professor Dr. Riazuddin, former professor at Calicut Medical College, and currently he is head of Department of Pediatric Gastroenterology at Kannur Medical College. Welcome, sir. I invite Dr. Sibi Srivatsan, ICH PG, to present the case.
Good evening, everybody. Now we shall discuss a patient with chronic liver disease, and this case is being presented by Sibi, is one of the best residents of ICH. Know that there are different types of examinations, and I'll be asking questions right from the word go. Okay, and most of the questions will be projected also. Okay, and I have to catch a flight in 40 minutes. Next 40 minutes. I'll make it as short as possible. Okay.
Good afternoon, everyone. Without much ado, we'll proceed to the topic per se. An 80-year-old boy born to third-degree consanguineous parents.
Okay. So what's the relevance of consanguinity in this child with the suspected chronic liver disease? You've got a child with suspected chronic liver disease. What's the importance of consanguinity? Is it important or not? Quick. Sibi?
Yes, a lot of liver diseases
Like-
are autosomal
like
recessive, like Wilson's disease.
Okay.
So consanguinity plays an important role here.
Anything else you know?
Uh,
Galactosemia, hereditary factor
hereditary
syndrome, the
factor
various types
intolerance.
of PFIC disorders,
PFIC.
etc. Okay.
The child had jaundice for past 4 years.
Now, what questions should you ask to a jaundice patient? Suppose you got a child with jaundice. There are two important questions to be asked to find out the type of jaundice. What is the first question? What is the second question? What is the first question to be asked to the patient? What is the color of urine? What's the color of urine here, CB?
It is a high-colored.
High-colored urine. That means this is not unconjugated jaundice. This child has got a conjugated jaundice, which may be either hepatocellular jaundice or cholestatic jaundice. So, what is the second question to be asked? What is the color of the? What is the color of the stool? What is the color of the stool?
Darker.
That is normal stool. Normal stool. That means this child has got a hepatocellular jaundice. So, we are dealing with a child having hepatocellular jaundice or hepatitis. Now, what is the type of jaundice in this child? Not this patient. He has got where's the timer? Timer. Okay, okay. What type of jaundice is this? This patient has got high-colored urine as pale stool. So this has to be not in this patient, but this is a patient with cholestatic jaundice. Okay. Right.
The child was on indigenous treatment with Kira Nelly for 4 years. Jaundice is waxing and waning, but has never disappeared completely.
That means for the past 4 years, he is continuing to have jaundice, which has never completely disappeared.
Child also had abdominal distension for the past 4 years.
So, what are the cause of abdominal distension in children? You can't say fatty female, fertile female or 40 with fetus. It's not pediatrics. What are the cause of abdominal distension in children? Number one, a massive child with a massive organomegaly, massive hepatomegaly, splenomegaly, or nephromegaly. Another one is ascites, a child with ascites. The third important one is a child with a lump in the abdomen, like Wilms tumor or neuroblastoma. So these are the three important causes of a true abdominal distension in a child. Yes.
The child also had pruritus for the past 4 months.
Now, CBS written pruritus, and I have written in italics and underscored. Why? What is inflamed in pruritus? When you say tonsillitis, that is TIS. Tonsils are inflamed. What is inflamed in pruritus? The answer is nothing. Okay? The spelling is not correct, CB. So the correct spelling is pruritus. It's very commonly mistaken. It is pruritus and not pruritus. Okay? Okay?
Child had history of recurrent abdominal pain.
So a child with chronic liver disease having recurrent abdominal pain. What are the conditions? What are the complications you can expect? Causes of abdominal pain in a child with chronic liver disease. Whatever is the cause of chronic liver disease. This is the clue. What is that? Gallstones. So cholelithiasis. Second one is that may be complicated by cholecystitis. There can even be pancreatitis complicating Wilson's disease. So there are maybe other causes also, but these are some of the important causes of recurrent abdominal pain in a child with chronic liver disease.
The child had no history of recurrent lower respiratory tract
So a
infection.
child with chronic liver disease, CB is saying that there is no history of recurrent LRA. What are the causes of recurrent LRA in a child with? Suppose this child does have recurrent LRA, what are the conditions you will think of? Yes, quick. Think of one is cystic fibrosis. That can cause chronic liver disease, cirrhosis, bronchiectasis. Any other condition whose gene is on the 14th chromosome. Long arm of the 14th chromosome. It's a long name. That alpha 1 antitrypsin deficiency. The classic pulmonary pathology is emphysema, especially what type of emphysema it is? Pan-acinar emphysema. They can also develop bronchiectasis.
No history of constipation.
Now, CB is specifically saying that he wants to say that this child with chronic liver disease does not have constipation. Why? Why? How do you correlate chronic liver disease and constipation? What is the relevance of constipation in a child, this child with chronic liver disease? You want a clue? When the examiner asks you whether you want a clue, always say yes. The clue is asthma. Next clue, this. Hypothyroidism. How do you correlate hypothyroidism and chronic liver disease? Autoimmune hepatitis. So what is the clue? Asthma.
Anti-smooth muscle
Anti-smooth muscle antibody. The clue was anti-smooth muscle antibody. Well, autoimmune hepatitis, which definitely comes with DD, differential diagnosis of this child, may be associated with constipation. Why? Because they develop Hashimoto's thyroiditis. And Hashimoto's disease may present initially with hypothyroidism. Okay, that may be the relevance of. Hope that was in your mind.
Yes.
Okay, smiling. Okay. That is a mischievous smile. Okay.
Child had no edema. Loss of appetite was present. There was history of pruritus.
And pruritus is continuing there. You can see that. Pruritus. So which genetic disease may cause intractable pruritus, dysmorphism, chronic liver disease, and congenital heart disease? This is the Prince, I'm sure. You know that Prince is one of my best PGs, a UG as well as PG, and I'm very happy that she's doing. Can you please stand up? I'm very happy that she's doing DM neonatology here. Please give her a big hand. I'm sure that Princey would have seen this patient. This is one of my old patients. What are the findings? You can see that broad forehead, deep set eyes, jaundice, triangular face, pointed chin. This is Ehlers-Danlos syndrome. Ehlers-Danlos syndrome patients may present with intractable pruritus. That's also a chronic liver disease.
There was no history of altered sensorium or seizures. No history of prolonged bleeding from injection sites. There was no history of hematemesis, melena, petechiae, or purpura.
I have marked melena as red. Anything wrong there? How do you spell melena? It's one of the most commonly misspelled words in not only pediatrics but also in gastroenterology. The American spelling is melena. What is the British spelling? The British spelling is M-E-L-A-E-N. That's the British spelling. But remember that M should always be followed by E. Why? What's the tip for that? The term melena is derived from melanin. Okay, so that has to be, M should be followed by E and never, not E. Now, how do you classify GA bleed? He says there is no history of GA bleed.
No history of GA.
Suppose there is a history of GA bleed. How do you classify GA bleed?
Upper GA and
Depending upon the site of pathology. When the bleeding, the site of pathology is proximate to the ligament of Treitz. Now, where is the ligament of Treitz? At the duodenojejunal flexure. You can see the ligament of Treitz there, duodenojejunal flexure. When the pathology is proximal to the ligament of Treitz, you call it as upper GA bleed. What are the manifestations? How do they present? Hematemesis, melanomesis, melena. And lower GA bleed usually as hematochezia. Okay? Now, what is melanomesis? So when somebody is vomiting, the vomitus contains altered blood. That is called melanomesis. That means there's a slow bleeding in the stomach, and the gastric hydrochloric acid is converting hemoglobin to black compounds. It's also called coffee grounds vomitus. Okay? What is this? What is this? This is melena. Okay? Black, the definition black, tarry, sticky, highly offensive, loose stools. So that is melena. The melanomasis versus melena. Okay.
Child had no history of blood transfusion.
What is it trying to say? There is no history of blood transfusion. Is it just blood transfusion? Remember that any prick with a contaminated needle may result in hepatitis. Just not necessarily need not be blood transfusion, but any prick with a contaminated needle may cause hepatitis B. So what is the infectivity of hepatitis B? How infective is hepatitis B? Very infective. 1 ml contains 1 ml of blood contains 1 trillion viral particles, whereas the infective dose is, what is the infective dose of hepatitis B? It's extremely minute, just 0.00001 ml. So the infective dose is extremely minute. It is 100 times more infective than HIV. Now, which is the most infective body fluid? That is the blood, and the least infective is tear. So the most infective is the blood, least infective is the tear. Now, what is this? Now, I was coming with Stevie in the metro, and I showed this photograph. We were discussing actually. He became excited. I said, what is this? He said, sir, this is very delicious chicken chettinad. This is not chicken chettinad. This is the classic stool of steatoria. He said, this is it. And he even said, sir, this is a nice chicken piece. Not nice chicken piece. So this is the typical stool of, this is the steatoria. Okay, you can see the oily stool. Okay, that is classically seen in a child with cystic fibrosis. Hope you already had your lunch, otherwise you may.
There was no history of passage of oily, bulky stools, no history of recurrent respiratory tract infections.
How will you call that? We already discussed that. Okay, cystic fibrosis.
History of easy fatigability present, no history of chest pain or palpitation.
Palpitation. Why does he want? Why does they want to bring in a severe symptom in a child with chronic liver disease? Palpitation. So, what is the relevance of anybody? What is the relevance of palpitation? Suppose this child does have a genetic disease like Wilson disease. Can it cause palpitation? Why palpitation? Sometimes there can be arrhythmias in Wilson disease. One of the manifestations of Wilson disease on the heart is to produce the cardiomyopathy and also arrhythmias. In such a case, there may be palpitation. Is that what you had in mind?
Maybe, sir.
He says, maybe, sir. Okay, fine. Drug history is also very important. You know, drug history is extremely important because what are the drugs that cause chronic hepatitis, chronic liver disease? This is one of our patients with a chronic liver disease. You can see that this is actually case of alpha-1 antitrypsin deficiency. He's got ascites, hyperosplenomegaly, edema, and he also had pan-acetyl emphysema also. So what are the drugs which may cause chronic hepatitis? Most common drug should be, in our practice, should be INH. Several drugs, nitrofuran. What is the use of nitrofuran in pediatrics? Or a pediatric urology to be more specific, that's used as a uro-infective and uroseptic agent. Then there are several other drugs like methyl-dopa, methotrexate, minocycline. So many drugs have been included. Did you get this history? Did you ask for this history? It's very important. History of, because you can't be sure that this is going to be Wilson disease. This may be due to a drug-induced liver disease also, because we use INH so frequently.
Antenatal history
We'll
was
try
uneventful.
to avoid unnecessary details because we don't have time. Antenatal anything?
It was
nothing. Uneventful. Family history, the most important aspect is born to third-degree consanguineous parents. Okay. What's the importance of immunization in this child? This is a child with chronic liver disease. So what's the importance of immunization? Any specific point regarding immunization in this child? He should be given all routine vaccines plus hepatitis B vaccine along with that. Plus, he should always begin hepatitis A vaccine also. Remember that all children with chronic liver disease should be given hepatitis A vaccine also. In fact, this is one of the most important indications for hepatitis A vaccine. Yes?
On general examination, child was alert, active, afebrile, pallor was present, icterus was present, there was no clubbing, no lymphadenopathy, there was no leg edema, there was no goiter.
Why goiter? Why did you say goiter?
Hashimoto's.
Maybe he has thought of the remote possibility of Hashimoto's thyroiditis also. But if you examine the child, you can see that his face is, looks like Cushingoid. Okay? He has got long eyelashes. He has got bushy eyebrows which are meeting in the middle. That's called cyanophrys. Okay? He has got hypertrichosis. Can you see that? He has got extensive hypertrichosis. Okay.
There was no cataract, there was no bite out spots, no subconjunctival hemorrhage, there was a ring around limbus, maybe KF ring.
He's got something like a KF ring. That's what he's trying to say. He feels that there is a KF ring. Okay. What is this? This is the classic appearance of KF ring. Of course, this child does not have such a ring, but you can always get it confirmed by a slit lamp examination. Now, how will you demonstrate KF ring? The best method would be to do a slit lamp examination. Suppose a slit lamp is not available, what will you do? Without slit lamp. So once I asked this question to one of our students in the examination, and she said, what examination? Sir, naked man's eye examination. This is what she said. Naked man's, it's not naked man's eye examination, naked eye examination, without slit lamp examination. Don't say naked man's eye examination. No, is it pathognomonic of Wilson disease? Can it be seen in any other condition? Remember that KF-like rings may be seen in any child with prolonged cholestasis. Any child with a prolonged cholestasis, you may get KF-like rings. Only thing is that they may not be complete, and they can be demonstrated only by slit lamp examination. Examples are PFIC. So many Alagil syndrome, sometimes you may find KF ring. Which layer of the cornea is the KF ring seen? The tip, what is the tip for that tip is KFD. What is the usual KFD? Chiasson-Forst disease. KF-D is the KF ring is seen in the Descemet's membrane. What is Fleischer's ring on the other way? It's not Fleischer's, not case of Fleischer, but what is Fleischer's ring? You can't say, yes? That is seen in a condition called keratoconus. That does not cause a liver disease, keratoconus. And the classic sign of keratoconus is demonstrated. What is that? Munson's sign. Munson's sign. It is due to deposition of hemosiderin, not copper. Hemosiderin deposition. Now, what are the signs of chronic liver disease? Can you mention some of the signs of a chronic liver disease? This child is supposed to be having a chronic liver disease. What are the signs? Quick. One is clubbing, leukonychia, spider nevi, paper money skin, loss of pubic hair. So many signs have been discussed. Notice this. This is palmar erythema. Okay. Now, what are the cause of palmar erythema? Can you mention some of the cause of palmar erythema? Any physiological cause? And once I gave a clue to one of our students, this physiological boy, to a boy, this physiological condition is seen only in females and caused only by males. Seen only in females, caused only by males. He looked at me for some time and said, blurted, sir, menstruation. So it is pregnancy. Pregnancy is a hyperestrogen condition, pregnancy. So pregnancy, chronic liver disease, chronic fibrosis, rheumatoid arthritis, leukemia, and this. What is this? A bike which is not Hero Honda. Then you will say, sir, Hero, Bajaj, Kawasaki disease. Kawasaki disease can also cause very striking palmar erythema as well as plantar erythema. Okay? What will you specifically look for in the eyes of a patient with chronic liver? For example, this child is supposed to be having chronic liver. What are the specific findings you look for in the eyes? Jaundice, always look for jaundice. Here it's already mentioned that subconjunctival hemorrhage, bite out spots, and KF rings. What is this? It's not a moonflower, so it's a sunflower cataract. Sunflower cataract. What is the synonym of sunflower cataract? Who describes sunflower cataract? Sibi?
Olaf.
Very good, Olaf. When was it described? It was described in 1922. It's also known as Olaf cataract, sunflower cataract. Does it affect vision? It's a very important question. Suppose the patient with Wilson disease has developed this cataract. Will it affect vision? It does not affect vision because it's caused by reversible copper deposition. It is reversible. It's not a permanent phenomenon. So, sunflower cataracts do not affect vision. Vision will be normal in spite of sunflower cataract. Name the only other condition which may cause sunflower cataract. Yes, somebody is. Chalcosis or copper foreign body in the eyes. Chalcosis or a copper foreign body in the eye. What type of cataract is seen in galactosemia? Oh, that is oil drop cataract. This is one of our patients. I'm sure Prince would have seen this patient with galactosemia. Now what is this? This is one of our patients with jaundice. You can also see he has got bite out spots. So our patient does not have bite out spots. No cataract. What are the cause of bite out spots in liver? This child has got a chronic liver disease. What are the causes? Why do they develop bite out spots? Yes. Sibi, any idea?
Cholestatic.
Cholestatic jaundice. What happens in cholestasis? Fat-soluble vitamins A, D, E, and K cannot be absorbed. Decompensated chronic liver disease, when the liver disease is advanced. Why? Because the transport protein is a retinol binding protein. The damaged liver is not able to synthesize sufficient amounts of retinol binding protein. Okay, so vitamin A cannot be transported. These are the changes. What are the nail changes of chronic liver disease? What is this? What are the findings you see here? Yes, clubbing and leukonychia. You can see two findings here. You can see clubbing as well as leukonychia. What is Terry's nail? Head of Terry's nail? What are Terry's nail? Just look at the nail. The 80%, approximately 80% has become opaque, and the distal 20% is retaining the normal pink color. So this is called an 80 and 20 nail or Terry's nail, classically seen in chronic liver disease. On the other hand, what is this? You can see that 50% of the nail is opaque and 50% is retained the normal. This is called a 50 and 50 nail. Which condition is it classically seen? It's called Lindsay's nail or Lindsay's sign. And this is classically described in chronic kidney disease. So in chronic kidney disease, you get Lindsay's nail and Terry's nail in chronic liver disease. What is the specific nail change of Wilson disease? Anybody? CB, what is specific?
Blue lunula.
Very good. Blue lunula. The lunula becomes blue. So you can see that. You can see the normal lunula and the lunula which has become blue in Wilson disease. What's the other name? This is all called azure lunula. A-Z-U-R-E, azure lunula. Blue lunula is actually a very rare manifestation of Wilson disease, seen in just 8% of children with Wilson disease. What are the drugs which may cause blue lunula? One is minocycline, the second one is zidovudine, is the antiretroviral drug. So both minocycline and zidovudine may cause blue lunula.
What is the nail finding in severe hypoalbuminemia?
Suppose a child, what is the cause of hypoalbuminemia? Apart from decompensated chronic liver disease. Pardon? Nephrotic syndrome. What is common to Bangladesh, Uganda, Congo, Tanzania? A condition described by Cecily Williams. Cecily Williams described Kwashiorkor. So, Kwashiorkor. So, these are some of the other. The nail change is called Muir-Case lines. In you find one or more transverse bands across a nail, which are parallel to the lunula. So, Muir-Case signs or Muir-Case lines are classically seen in any condition that causes hypoalbuminemia, not necessarily decompensated chronic liver disease.
In skin, there was no rash, petechiae, purpura, spider navy, but scratch marks were present. Chest was normal. Abdomen, no umbilical hernia.
Abdomen is distant.
External genitalia was normal. Limbs and spine were normal.
What will you specifically look for in the bones? In a child with a decompensated chronic liver disease, you look for features of rickets. Rickets will be common. This child doesn't have features of rickets. But what are the features of rickets? What are the mechanism of rickets in chronic liver disease? Why do they develop rickets? There are so many causes for developing rickets in chronic liver disease. Poor exposure to sunlight. Why poor exposure to sunlight? These children may not be able to go out and play. Okay, so poor exposure to sunlight. Deficiency of bile salts in chronic liver disease. Defective hydroxylation or the 25 hydroxylation. Defective 25 hydroxylation. Why? Because the hepatocytes are damaged. The diet may be poor in vitamin D. Because these are some of the causes. And if there is steatorrhea also, suppose the child, cystic fibrosis, steatorrhea also, that will aggravate the malabsorption of vitamin E. So these are some of the features, causes, mechanisms why they develop biliary rickets. It's called biliary rickets.
Vitals, heart rate was 90 per minute, regular in rhythm.
What's the importance of pulse in this child? Child with chronic liver disease. Suppose the pulses suddenly become low volume. That means he may be having a GI bleed. Okay? Arrhythmias. Maybe in Wilson disease you can get arrhythmias. What's the importance of the pulse? The arrhythmias. Okay. Then relative bradycardia. Suppose he has got a bradycardia. What may be the cause? What are the causes of relative bradycardia in chronic liver disease? One is before drug. Suppose this is a cholestatic liver disease. In cholestatic liver disease, the bile salts which are deposited in the SA node may depress the cell. That's one of the theories. Second one is the drugs like propranolol, which may be given to these children to prevent bleed.
Respiratory rate was 30 per minute. BP was 90 by 60 millimeters of mercury.
Nothing much. On anthropometry, one of the striking features of this child, I just saw this child, he's very short. He's 8 years, but his height is only 100 centimeters. So what is the cause of such marked stunting of growth? His height is just 100 centimeters. Okay.
Abdomen inspection. Abdomen is distended, flanks are full, umbilicus is pushed down and slit-like. All quadrants move equally with respiration. Dilated veins are present over the abdomen.
This is another child with dilated veins. Okay. What type of portal hypertension is this? This child is having portal hypertension. Is it intrahepatic or extrahepatic? It's a very supposed to be a tough question, which students usually find it difficult to answer. What type of portal hypertension? Is it intrahepatic portal hypertension or extrahepatic portal hypertension? You know that? Now, in mythology, Kijaka was destined to be killed by whom? Kijaka was destined to be killed by, so very tough question.
Bhim.
Bhim. Okay, very good. So Kijaka was supposed to be killed by Bhim. So if Kijaka has been killed, that means Bhim is responsible. Kijaka killed, Bhim is responsible. Similarly, if a patient has got dilated anti-abdominal wall veins with flow away from the umbilicus, the cytopathology has to be the liver. That is an intrahepatic portal hypertension. Okay. If Kijaka is killed, Bhim is responsible. Similarly, if there are dilated anti-abdominal wall veins, the pathology has to be within the liver. It is intrahepatic portal. I tried to explain that further. The anatomy of what is the length of the portal vein? It's about 8 centimeters. Okay. It has 2 parts. It's got a long extrahepatic part and a short intrahepatic part. The intrahepatic part is divided into the left branch and the right branch. And the umbilical vein joins the left branch of the intrahepatic portal vein. Okay. Suppose the patient has developed cirrhosis. So the pressure within the liver is increased. So this pressure will transmit blood through the hepatic vein into the umbilical vein. Okay. This umbilical vein reaches the umbilicus. From there, it will spread on to the collaterals which are patent over the anti-abdominal wall. Okay. So in cirrhosis, you get intrahepatic portal hypertension. And that's the reason why the blood is flowing through the umbilical vein, the pro-patent umbilical vein, towards the umbilicus. And from the umbilicus, it spreads on to it flows to the collaterals around the umbilicus. That is responsible for the dilated anti-abdominal veins with flow away from the umbilicus in intrahepatic portal hypertension. On the other hand, suppose the patient has got extrahepatic portal hypertension. Can you see that? The block is somewhere here. So what happens to the pressure within the liver? The pressure within the liver will never be increased because actually the blood supply to the liver is decreased because the portal vein is obstructed. That means the pressure in the liver will be normal or even decreased, and hence blood cannot flow through the umbilical vein to the anti-abdominal wall. So you will not get dilated anti-abdominal wall veins in extrahepatic portal hypertension.
Abdomen is distended, flanks are full, umbilicus is pushed down and slit-like. All quadrants move equally with respiration. No visible pulsations. Hernial orifices are free. External genitalia is normal.
This is another patient. What is the finding here? This patient with the biliary atresia has undergone a Cassai's operation. So this is the terminal stage of Cassai's operation. Okay. You can see the large number of dilated anti-abdominal veins. You can see an echoed umbilical hernia. The other one is an incisional hernia. Okay. So many findings.
Liver is palpable 14 centimeters below the right costal margin, firm in consistency, smooth surface, sharp borders, and non-tender.
You should always say the liver is palpable 14 centimeters below the right costal margin in the midclavicular line. Not mentioned in the midclavicular line. And you should never forget to measure find out the midclavicular line also. How do you find out the midclavicular line? I'm sure you know how to find out the midclavicular line. How do you mark the liver? With a pen, marker pen. Should never draw on somebody else's abdomen. Always use a chalk. Otherwise, what may happen? Suppose you mark the liver as 15 centimeters below the right costal margin. You mark it. You go back, and the next person, your friend who is coming next, you also feels it is 15 centimeters below the right costal margin. So you'll fail not only yourself but also your friend who is coming next. So always mark with a chalk, and don't forget to rub it off also.
Spleen is palpable 5 centimeters along the long axis, firm in consistency, smooth surface, anterior notch felt, no other mass palpable. On percussion, liver span is 18 centimeters.
Now, what are the signs of ascites? Free fluid in the peritonium. What are the signs of? What are the clinical signs of ascites? One is flank dullness, shifting dullness, fluid thrill, and puddle. These are the three or four important signs, clinical signs of ascites.
Shifting dullness is present.
See, it will be very difficult to demonstrate shifting dullness in this particular patient. Why? Because he had a huge hepatosplenomegaly. The liver is palpable 14 centimeters, spleen is also almost 14 centimeters. So it will be very, I do not know, he should be a very meticulous, a very brilliant clinician because he has demonstrated shifting. It will be very difficult to, because the huge hepatosplenomegaly, it will be very difficult.
On auscultation, normal bowel sounds heard, no bruit, venous hum or friction rub.
Significance of bruit. Suppose you hear a continuous murmur in the epigastrium. What is that? We'll come to that later. So, who was Dr. Puddle who described Puddle's sign? Options, a pediatrician, second option, pediatric gastroenterologist, third option, adult gastroenterologist.
Pediatricians.
He wants pediatrician. You don't like pediatric gastroenterologist?
Pediatric gastroenterologist.
Pediatric, oh, he's very
When the captain says march, we march.
Okay, that's very nice. So he's very fond of pediatric gastroenterologist also. Okay, thank you very much. But then, Puddle is not a doctor. Puddle is just a collection of water after a sharp shower. Okay, a puddle is just a collection of water after a sharp shower. So Puddle is not a doctor. Anyway, I'm happy that he mentioned pediatric gastroenterologist. So this is it's a very cumbersome procedure. I don't try to demonstrate Puddle's sign. What is the importance of auscultate the abdomen in this child? Suppose you want this particular child. Should you auscultate? You are auscultating the epigastrium. What's the importance? In a child with cirrhosis, portal hypertension, intrahepatic portal hypertension, we already mentioned that the umbilical vein is full. So you may hear a continuous venous hum or a murmur. What is this murmur called? Usually undergraduate students are very fond of this. What is it? Yeah, that's called the crew will hear Baumgarten murmur. Okay, they are very fond. I was very fond of it when I was very young. Okay. So crew will hear, you heard of that, CB?
Yes, sir.
Crew will hear Baumgarten murmur, suggestive of portal hypertension. It is always there. Remember that you will never hear this murmur in extrahepatic portal hypertension.
Cardiovascular system, first and second heart sounds heard, no murmur.
Okay, no, everything is CVS is normal, respiratory system is normal, nervous system appears to be normal. Okay, I'll believe that. So, summary. See, at the end of the clinical examination, you are supposed to summarize. Summarizing is actually an art which has to be perfected. Usually, you make a mess out of the summary. It won't be a summary, it will be a long history. See? It should be like a micro mini skirt. Should be very short, it should be exciting, and should reveal everything in a few words. So don't make it very long. But this is what CBS prepared. Is it a long skirt or a short skirt? I think it's a very, very long skirt. Not a very, very long skirt. So I had just summarized this. Just look at it. 8-year-old boy born to consanguineous parents, which I imply that is a genetic disease. Okay, prolonged jaundice, firm hepatosplenomegaly, ascites. That means this is a decompensated liver disease. Plus KF-ring. There's no other diagnosis. So this is a decompensated chronic liver disease. Cirrhosis with portal hypertension. Most probably you will say. Is it a short skirt or long skirt? This is short skirt. Okay. So what are the points in favor of Wilson disease? Consanguinity, history of liver disease in the father. We don't know what has happened to the father. Father has got a liver disease.
Liver disease.
What the most common liver disease in fathers? Alcoholic liver disease. We do not know. Okay. The long history and the fact that he has got a KF-ring, especially if an experienced ophthalmologist also say that he has got an unequivocal KF-ring, then that has to be very significant. So these are some of the, we'll come to that later. What are the differential diagnoses? Do you think that it's only Wilson disease? Can it be any other disease? Or what are the conditions which come in the differential diagnosis? Suppose there is no KF-ring. What is the most common condition to be ruled out? That is infection. Which infection? That is chronic hepatitis B. No, chronic hepatitis B. C is very rare, but always think of chronic hepatitis B. Drug-induced, never forget about drug-induced liver disease, especially in places like Tamil Nadu, where indigenous drugs are very popular. Even in Kerala, indigenous drugs are very popular. autoimmune hepatitis. Never forget about autoimmune hepatitis and various other metabolic liver diseases. What are they? Like this. Remember that galactosemia usually presents in newborn period, but it can present at any age. Even adults may develop it. These are some of the other conditions which may present as a chronic liver disease. How will you investigate? So these are the important investigations. Complete blood. What's the importance of peripheral smear? In this child, what's the importance of peripheral smear? Peripheral smear. What is the finding in Coombs negative hemolytic anemia? Maybe one of the most important findings in Wilson disease. LFT, prothrombin, ceruloplasmin, slit lamp, 24-hour copper, liver biopsy. It's already undergone a liver biopsy. And viral and autoimmune markers. We should always rule out autoimmune hepatitis in this patient. What's the finding in this? You can see microspherocytes. Can you see the microspherocytes? You can also see a normoblast. That's a normoblast. That's a normoblast. These are microspherocytes. These are commonly seen in Wilson's disease. So any child with unexplained hemolytic anemia, think of the possibility again of Wilson's disease. So is the time for some revision questions? Okay, we'll ask some revision questions also. What's the most important clue for diagnosis of jaundice? The most important clue is suspicion. Just like this Alfred Hitchcock thriller, Suspicion. It's an old movie starring Cary Grant and John Fonda. You should suspect other condition. Don't feel that this is going to be Wilson disease alone. This may be some other condition. For example, I feel that he's got some features suggestive of Hunter syndrome or Hurler syndrome because of the hypertrichosis. He's got bushy eyebrows. He's got cyanophrys, hypertrichosis. So many features. And the liver and spleen are quite large. So these features, and he's got marked stunting of growth. His height is just 100 centimeters. Is 88. So because of these features, it could be some other condition also. So always think of others. So suspicion is very important. Now, how do you approach a child with jaundice? What's the first step? First step in a child with jaundice, any child with jaundice is history taking. Okay, the history taking. The second step, and even third step is also here. Why? In the examination, you need not write history 3 times. I have written this here just to emphasize the importance of a proper history taking. If you do not take a proper history, you will miss the diagnosis. Then you examine the child and do the relevant investigation. So pediatrician should be like whom?
Sherlock Holmes.
Like Sherlock Holmes. Not only pediatricians, all doctors should be like Sherlock Holmes. What is Mednick syndrome? Anybody has heard of this condition? Mednick syndrome. You may maybe ask as a short note. What is Mednick syndrome? What is Mednick syndrome?
Combination of both Wilson's with Menkes kinky hairs.
That's right. The relatively new entity, one of the copper overload conditions, treatment is using. You can look up later what is Mednick syndrome. Okay. What is melanomesis? Revision questions. What is melanomesis? That is vomiting of altered blood, coffee grounds vomiting. What is Hy's law? Hy's law. That is, if a patient is on ATT and the SCPT becomes 3 times above normal with jaundice, jaundice means the serum bilirubin is more than 2.5 milligram/%, then that drug causes a very high mortality of almost 10 to 50%. So whenever you put a patient on ATT or hepatotoxic drug, including anti-epileptics, always monitor the transaminases and serum bilirubin. If the patient develops visible jaundice, the mortality is going to be very high and he may even require liver transplantation. This is called the Hy's law after this famous hepatologist. Which chromosome is the gene of ceruloplasmin located? On which chromosome is the gene of Wilson disease located? Pardon? CB? Gene of Wilson disease. What's the nickname of Wilson disease?
Unlucky disease.
The gene of Wilson
13Q.
disease. So which chromosome is gene of ceruloplasmin located?
3Q.
He says 3Q. He's very sure about it. Please give me a big hand. He's right. So the gene of ceruloplasmin is on the 3rd chromosome. The Wilson disease is on the 13th chromosome. What's the experiment animal in Wilson disease? If you do not answer, you will answer. CB?
Long event cinnamon rat.
This is the experimental element. Long event cinnamon rat is the experimental animal of Wilson disease. What is the staging system called? What is the staging system of Wilson disease?
Modified Calicot system.
Modified Calicot. That is scoring system. Staging is called Dease staging. This is the liver biopsy finding of a child with chronic liver disease. One of the classic presentations. What is the finding? What is the diagnosis? This is alpha-1 antitrypsin, PS positive, diastase resistant, magenta colored globular inclusions within the cystine of the endoplasmic reticulum of periportal hepatitis. This is one of the classic liver biopsy findings in chronic liver disease, alpha-1 antitrypsin deficiency. Terry's nails. What are Terry's nails? 80 and 20 nails. Okay, and what is this? This is Lindsay's nail or 50 and 50 nails in chronic kidney disease. Can the mother on deep insulin breastfeed? Yes or no? Should not breastfeed because this drug is excreted in the breast milk and might harm the infant. So it's better not to breastfeed. What are the source of transaminases? SGOT and SGPT. What are the sources? Where are they from? SGOT is, which is liver specific? SGPT is liver specific. Remember that SGOT, there are so many sources, not only from hepatitis, cardiac muscle, skeletal muscle, brain, pancreas, lung, RBC. So even if there is hemolysis, there can be elevation of SGOT. Whereas SGPT is liver specific. It's present only in the hepatocytes, mainly in the hepatocytes. So if a patient has got elevated transaminase SGPT, that means he may be having underlying liver disease. What is this ratio called, SGOT-SGPT ratio?
Berman's ratio.
No, it's not SGOT-based, it's not Berman's ratio, that's different. Anybody? That's called de-Rette's ratio. De-Rette's ratio. If it is more than 1, for example 2:1, it may be seen in Wilson's disease and alcoholic hepatitis. The reasons you can look up later. Can you get alcoholic hepatitis in children? Quite possible in adolescents. We had a patient, a tribal child in Calicut, who was admitted for encephalopathy. Then we found out that he had drunk the charayam. Charayam means, what is charayam? Arak of his father. So it's quite possible. Alcoholic hepatitis can happen in pediatrics also. Another condition, whenever you find a child with unexplained elevation of transaminases, especially when the SGOT is more than SGPT, always think of the possibility of an underlying liver disease. He may be having Duchenne or some other myopathies. So these are some of the causes of unexpected elevation of transaminase. Obesity is one of the most important ones. See? Unexplained transaminases, think of obesity or diabetes. What is NASH? Non-alcoholic steatohepatitis. Asymptomatic chronic hepatitis B, hepatitis C, Wilson disease, alpha-1 antitrypsin deficiency. Low ceruloplasmin, is it possible? Low ceruloplasmin, normal neonates. That's the reason why it's very difficult to biochemically test a child neonate with them for Wilson disease. It will be normal. Kwashiorkor. Why Kwashiorkor? Kwashiorkor is just like albumin. It's a plasma protein. So if albumin is decreased, naturally ceruloplasmin may also be decreased. Nephrotic syndrome, a lot of ceruloplasmin will be lost in the urine, protein losing enteropathy, and several other conditions also like Menkes Kincaid disease, hereditary aceruloplasminemia. Remember that 10% of heterozygotes for Wilson disease also, the ceruloplasmin may be low. What is the cause of sudden death in a Wilson disease? You got a child who is doing extremely well. He's doing well on deep end, but he suddenly dies. What may be the cause? Arrhythmias. Always think of the, it may be rare, but cardiomyopathy has been described and cardiac arrhythmias too have been described in children with Wilson disease. What's the relevance of this animal? What is this animal? CB?
Sir, pandas.
Panda. Can you qualify the panda? Giant panda. It's a big panda. Big panda. Giant panda. So what's the relevance of this animal?
In T2 weighted images in MRI in Wilson's disease.
That's the classic MRI finding of neuro-Wilson disease. Face of a giant panda. Face of a giant panda. You can see the classic MRI appearance of neuro-Wilson disease. What is this MRI finding?
Eye of tiger.
Eye of tiger. Where do you get eye of tiger appearance? That is in Halloward-Spatz disease. These are some of the food items should be avoided in children with Wilson disease. It's called an unlucky disease, not only because the gene is on the 13th chromosome, but also because they are forbidden from eating chocolates, which they are very fond of. How long should we continue copper-restricted diet in Wilson disease? Remember that once the patient is stabilized, is on maintenance therapy, then this dietary restriction should be avoided. Because you should remember that copper is an essential nutrient for the growth of children. If there is no copper, there can be so many problems. What are the special advantages of zinc in Wilson disease? Zinc. Zinc acts by inhibiting copper absorption. It increases metallothionein synthesis in the gut and liver. It induces synthesis. Metallothionein has a great affinity for copper than zinc. And this metallothionein bound copper will be sloughed into the gut and excreted in the stool. Okay? Not only that, remember that our body secretion like saliva, gastric juice, etc. contain almost 1 milligram of copper. this copper will also be reaching the gut, and that can also be absorbed into the bloodstream with the help of zinc. The zinc will prevent the absorption of this copper also. That means zinc can even decrease tissue copper level. That's the reason why zinc is going to be a very exciting drug. The point is that it does not aggravate neurological features. It is not teratogenic, unlike dipensilabine and trientine. Very cheap. Dose is 75 milligrams per day. What the peculiarity of ceruloplasmin in pregnancy? Remember that ceruloplasmin levels may increase gradually during pregnancy, and it will be lowest at term. So if you are having a patient with suspected Wilson disease who's at term, then it will be difficult to diagnose. Ceruloplasmin will not be useful. Suppose a patient is on a treatment for Wilson disease and is about to undergo an emergency surgery, some surgery. What precaution should you take? CB, any idea what precaution should you take? Remember that penicillin may interfere with wound healing. It affects collagen, so it may interfere with wound healing. So before surgery, the dose of penicillin, D-penicillin should be reduced, but not stopped for 10 to 14 days after surgery. So this is a very important practical point. It's important to reduce the dose to make it 50%. The drug of choice in neuro-Wilson disease? Drug of choice, CB?
Trientine will be better.
Trientine is the drug of choice. The drug of choice is ammonium tetrathiamine. This is the best drug in neuro-Wilson disease. Unfortunately, it's not freely available. The dose is 30 milligrams twice daily. This is a very useful drug, especially in neuro-Wilson disease, which is unfortunately not available. Now finally, how should pediatricians tackle a child with suspected Wilson disease? A lighter answer, don't take it very seriously, okay? So we should be very enthusiastic. So we should be aggressive when you're tackling a child with Wilson disease, like Siddhan. European pediatricians are actually very more aggressive. So this is how they tackle it. See? Now, who are the most aggressive people in the earth now? The Americans. Let's see how the American pediatricians tackle Wilson disease. Extremely aggressive. You should not exercise such amount of severe aggression. But then, what do we do when we get a child with Wilson disease? Suspected Wilson, jaundice, 1 year jaundice. So what do? So you give some leaf 52. You tell the mother, parava. And you'll never make a diagnosis, and the patient will die of his own without a diagnosis. This should never happen. Thank you so much.